afternoon. I'm Haley Hovius, President of the Nashville Healthcare Council. I'd like to thank all of you for choosing to spend the next hour with us for the third and final installment of our series on health equity and action to eliminate disparities. The Council is committed to working toward a better tomorrow by taking these first steps to better understand the long-standing inequities and injustices that exist in many of our country's basic institutions. We're thrilled to be able to partner with Nashville Health to explore these important issues around health equity. Now, before we get started, I'd like to take this opportunity to thank today's sponsor, RL Datix, for making today's event possible and supporting efforts to combat systemic racism in our industry. A few quick housekeeping notes before we get started. We'll be taking questions via the Zoom chat feature that's found at the bottom of your screen. And finally, we'll be sending you a survey after the event. Now more than ever, we want to know from you your thoughts on how we can deliver council content and networking activities as effectively as possible. And now it's my pleasure to introduce Caroline Young, Executive Director of Nashville Health, an initiative focused on improving the health of the citizens of Nashville. We have been absolutely delighted to be able to partner with Nashville Health on this important initiative and can't thank Caroline and her team enough for everything that they've done to make this possible. Caroline, I'm turning it over to you.
Thank you, Haley, and good afternoon to everyone. I want to echo Haley's appreciation for you all joining us today, and for those of you who have been with us in our previous two conversations. At Nashville Health, we found these events to offer insightful, authentic, and thoughtful guidance on understanding disparities and confronting inequities. And I know personally here at Nashville Health, we will be using them not only in the near term, but moving forward in our work to improve health and well-being here in Nashville and beyond. And I hope you will too. I'm also very excited about the conversation today and the guidance we will receive from our experts. And with that, I'm going to hand it over to our moderator, Senator Bill Frist, former U.S. Senate Majority Leader, and also founder and chairman of Nashville Health. Senator?
Caroline, thank you. And thanks to Nashville Health and the Nashville Healthcare Council for hosting these timely and vitally important discussions on health equity and health disparities. The COVID-19 pandemic has laid bare the hard truths about disparity here in Nashville and cities around the country, around Tennessee, and really nationally. And it's critical for all of us to stand up and to confront what may be entrenched practices and beliefs to make real changes and ultimately improve health and well-being. Our guest today, and I'm really excited about our two guests today, will discuss efforts to address inequity at the patient level, and it'll include research and at the bedside. So let me introduce them, Dr. Joe Cashone and Nyesha Foster. Dr. Cashone is Executive Vice President, Clinical and Network Services at Ascension, where he oversees the system-wide clinical and care functions and subsidiaries with the goal of addressing the holistic needs of patients. Prior to joining Ascension in 2017, he served as Chairman of Operations and Strategy at the Cleveland Clinic's Heart and Vascular Institute. Dr. Nyesha Foster is Vice President, Product Access, Global Health, and Patient Access, where her team is focused on addressing the patient affordability challenge. In this role, she is accountable for U.S. patient assistance programs, international product to donation programs. Ms. Foster also leads Pfizer's Multicultural Center of Excellence, which advances the health equity in diverse communities. I'd like to start by asking each of you to provide our audience with a quick overview of your individual organizations. And people know Pfizer and people know Ascension, and they're familiar to all, but we may not truly fully understand the scope, the mission, the size. So let me first turn to Nyesha, and then Joe, why don't you follow right after that? Nyesha.
Thank you so much for having me here today. So Pfizer's mission is quite clear and simple. It's breakthroughs that change patients' lives. And we practice this and put this into action by applying science and our global resources to bring therapies to people who need them the most. We are focused on quality and safety at the forefront and ensuring that the value of the discovery and development process is brought to bear for all of our products. We are focused in several therapeutic areas, including oncology, internal medicine, vaccines, inflammation, and rare disease. Every day, our Pfizer colleagues, they come to work and they think about not only what we can discover just to put on the shelf, but actually how we bring that product to all patients who may need them. And that's where my group comes into play. I sit within our corporate affairs team, and my team is responsible for thinking through, once a product is commercialized, where do the different patients who may need that medicine sit, and how might we create creative solutions to bring that product to those patients. In the US, we focus on patients who are unable to afford our medicines through a program called RX Pathways. And through RX Pathways, we're able to provide currently nearly 60 medicines for free at a discount for those who can't afford them, depending on the level of their household income. At Pfizer, it's not just about here in the US. Of course, we're a global company. And so my team also looks after a signature international product access program called the International Trachoma Initiative. We'll talk a bit more about that later. And then also we don't think we can do anything by ourselves. So the Multicultural Center of Excellence that myself and my colleague oversee is a combination of 40 different organizations across the US, national organizations, and a couple of local ones as well. And we look over the health equity initiatives that those organizations are advancing in historically disregarded and therefore underrepresented communities such as African American, Latino, Asian, and we've also added LGBTQ and disabled organizations to the mix recently, and Native American. And so we work with them to figure out what those barriers are in those communities. We seek to bring our knowledge to help them address those issues. We fund different initiatives, and then we create new partnerships. I'll talk about some of those later as well. So that's Pfizer. That's where I sit, and happy to be here today.
Great.
Dr. Cashone.
Good, Joe.
Yeah, thank you, Anisha, and thank you to Pfizer for the work on the vaccine, which we're all waiting on. And so we really do appreciate the work that Pfizer's done. Ascension is one of the largest health systems in the country, non-for-profit health system. You all know it by St. Thomas in the Nashville area. We have the 155 hospitals across the U.S. We're in 22 states and employ 10,000 doctors. And, we are a faith-based organization based on Catholic Church and Catholic Church, and we are a ministry of the church, actually, the way it's defined. And our mission really calls us to pay particular attention to the healthcare needs of everyone, but in particular to those, the poor and the vulnerable. And health equity is what we wake up every day to think about, is how do we deliver health equity? And you'll hear more today from us about the things that we're doing to better measure the lack of health equity today, and how do we, and until we can measure it effectively, we can't really implement things because we don't know what our results are. So we want to be very quantitative on how we can affect health equity and how we can drive outcomes in this population. Last year, Ascension did about $2.5 billion worth of charity care across the U.S., making us one of the leading providers of charity care in the United States. And we continue to be committed to our mission of caring for this poor and vulnerable population. And what this pandemic has really exposed is those folks are more susceptible because of these inequities in some of the social determinants that are out there, housing, things like that, food insecurity. And we have some information we're going to share today on some of the information in the Nashville area and then nationally about health equity and how the pandemic has really exposed us even more going forward. So we're really happy to be here. We're happy to be part of the Nashville community, and looking forward to a lively discussion. Thank you, Bill.
Good. Naisha and Joe, thank you for those introductions, and clearly both huge organizations with huge reach, and in Pfizer's case, of course, the global reach as well. Naisha, let me start with you. As Pfizer operates across borders and serving patients from literally every corner of the planet, how are you working to understand patient vulnerabilities and tearing down those barriers to improved health?
Yeah, thanks for the question. So I think our breadth and reach across the globe allows us to really sit in these local markets and understand how health systems operate, how patients are able or unable to access care, and those barriers that are getting in their way. We are definitely grounded in our value of partnerships, and we work with multilateral organizations across the globe, as well as local community-based organizations, to identify ways to partner and remove those barriers. And we're permitted, we actually love speaking directly to the patients, right? They're the expert in their disease and their condition and can tell us the best what those barriers are. One of the programs that I introduced to you in my introduction is called the International Trachoma Initiative. And this is an international example, if I may. And trachoma is a disease that causes blindness. We've partnered with many organizations, over 100 organizations, including using the WHO framework around, it's called SAFE basically, and it's around surgery, antibiotics, facial cleanliness, and environmental safety. And this structure allows us to, as Pfizer, to bring our antibiotic, Zithromax, to bear in this situation. And so our antibiotic can basically help with, as part of this overall structure, prevent this blindness that causes people to have poverty generation after generation. We have over 100 organizations such as Sight Savers. We work with the United Kingdom Department of International Development, the Queen Elizabeth Diamond Jubilee Trust, just many, to make sure that our product gets to the patient and it gets dispensed. I had the opportunity last year to go to Tanzania and actually see a dosing in a village. And just to think about years and years ago when this product was developed, to be able to see how it could change life, how it can change generational poverty, is something that you just can't measure. We've been able to cure trachoma or have it eliminated, excuse me, in about 10 countries now. Pfizer has donated over 900 million doses of Zithromax in this 20 years, and our commitment extends to 2025. And so that's one example outside the US. And if I can just talk a little bit about a US example, we partnered with National Urban League, as well as 100 Black Men, the City of Hope, on a project called Take Action for Health. And it's a web-based tool that helps people manage their symptoms, understand their disease, their educational materials on there, and also help them understand how to speak to their physician about their condition. Conditions such as cancer, hypertension, depression, a lot of that right now. And so these health screening tools combined with these educational webinars give the patient the ability to get more well-versed in the conversation with their physician, and also able to hopefully help eliminate these disparities that exist from these diseases. So that's an international and also a local, national examples on how we are partnering to help in this area.
Naisha, thank you. Joe, as you mentioned in the opening, Ascension is the largest nonprofit health system by far. It has over 2,600 sites of care. We think of the hospitals, and we have a wonderful hospital and system here with St. Thomas, but also long-term care, the outpatient facilities. How, and it's got to be challenged, but how do you place health equity as a strategic priority when you have such a broad spectrum across the country?
Yeah, and the one thing that I would say is that, first of all, I think we really focus. It's what we call our calling is really to focus on this health equity, and I think part of what it starts with is understanding the gravity of the problem. And so, in the last 8 or 12 months, we've now collected data on 72,000 patients across our ministries, including Tennessee. We've collected data on 72,000 patients on social determinants of health, and really looked at these social determinants by age class, by race, by ethnicity, and started to identify what are the consistent themes that are coming out in certain populations that need to be addressed. And then partnering with organizations such as Aunt Bertha to really place people and to connect people to the right community and assets that are available. You know, one of the things that we've seen during the pandemic over the last 9 months, we're collecting data on 11 different social determinants. The number one social determinant right now that people are identifying, first of all, out of that 72,000, 25% of those people, so 1 in 4 are identifying one of these social determinants as a potential problem. And we're slicing and dicing based on all the things I said, but the number one issue both in Tennessee and nationally has been social isolation through the pandemic. And in particular, in our elderly population. It's interesting, in the population age range from 20 to 55, it's more about money and employment. But in that older population, the number one social determinant identified is social isolation. And we think that's a direct result of the pandemic. So we are now connecting people to social through our various community assets that we have, things like you have in Nashville or in other large cities, connecting people. If it's food insecurity they have, we connect them to the food banks. If it's transportation issues, we connect them to the right social services to help identify those problems. So for us, it starts with correctly measuring and identifying those problems. One of the anecdote that we have is when we first started collecting this data, we had a lot of resistance from the doctors. They didn't want to collect the data because they didn't know what to do with the information. In the last 12 to 18 months, we have made great strides in figuring out what to do with this information and acting on it. And so we'll continue to drive, and part of our measures and what we're going to hold ourselves accountable to going forward in the national market and all the markets we serve is not just the quality of the care that's delivered in our four walls, in our hospitals or our practices, but what is the health of our communities? And so we will be focusing on that as an additional measure of our success as a health system, is what does the health of the communities that we serve look like?
Yeah, Joe, I really appreciate you using that as an example. You know, we've had all this data on health disparities for years, and I've written about it 15, 20 years ago. People have been writing about it for 40 years, and we're only now doing a better job collecting that data, and included in that data, of course, are the social determinants. And then the real key thing I think that the COVID has done is sort of looked at, so what do you do with that? And I think your example was very good, how if you have isolation, you go and do something about that. Naisha, Pfizer, again, let's stay on data for a while. This whole data of understanding unmet needs of vulnerable populations, disadvantaged populations, comment specifically a little bit about implicit bias. What is it? And you may even comment a little bit more specifically on patient access.
Sure, happy to do so. As it relates to bias, whether it be in systemic systems or in someone's everyday life, you just don't know what your biases are, right? You think you're doing everything right, but it could impact a decision that you make. And as a result of those biases, you may create additional health disparities. If you talk about patient access, specifically, I talked a little bit about our RX Pathways program, where we're able to provide discounts and free product to patients who are at the lower end of the economic spectrum. I would say probably over the last 5 years or so, we've been able to help over 1 million patients access our medicines that they wouldn't have been able to before. So it's this matter of ensuring that you understand what the data is saying when you're developing the product, whether it's socioeconomic or whether it's age. You make sure that you understand what those needs are so that when it does come to market, you're able to provide for those patients. We've also have an example of that now with COVID, right? So we see the health disparities that existed there. And what we were able to do through many avenues using data is understand where the pandemic was breaking out, where we had these research sites, whether or not the ethnic mix of the patient population in the area, did that site actually have relationships with underrepresented communities? And where they were not, we used our own networks internally to determine how we could make sure that people knew about a trial site. And we also work with our advocacy organizations to ensure that the materials that were being developed were culturally appropriate, at the right literacy level, and then distributed through some of our partnerships where they had the trust of the community, and knew that if they were involved in developing those materials, it's something that they should look into. So it's when you have all that understanding from the beginning and understand what some of those barriers are, you can then hopefully get to a place of trust and access and providing information that will be able to help people make a better decision.
And Joe, on implicit bias, again, Ascension is huge. It's huge and all over the country. What, sorry, how do you look at it, and how are you working within the company and Ascension more broadly, the corporate structure, to decrease implicit bias? I know it applies to the bedside and clinical decision making, but where do you start with implicit bias, and how do you ensure that the people involved have the knowledge and have the awareness to deliver excellent patient care, and where you're doing research, excellent research?
Yeah, I think we're very explicit about it. I mean, that's the thing is when we start holding ourselves accountable to quality metrics, we explicitly call out the vulnerable populations as one measure. We're not only measuring in the overall, but we also measure in populations that we think are at higher risk for these things. For example, breast cancer screening in African American women versus the general population. We know that has been lagging. Colorectal screening oftentimes lags behind. So we call it out, we hold ourselves accountable, and we call out the population in our metric, and we're held accountable by our board of directors explicitly to call out those specific populations that we feel are at most at risk. One of the things that we're seeing through COVID is severe maternal morbidity and mortality is going up in the COVID positive patients, and it's affecting both the overall population and affecting our Black African American population to a greater degree. And so we have to, I think we're just very explicit about calling it out and not being being explicit with our staff, our physicians, is to say, listen, this is real. The differences are real, and we need to fix the differences. So holding ourselves accountable to combat that implicit bias on the way we start to look at things. I always worry about the law of averages, right? If the average person does poorly or does okay on something, that means a certain number of them didn't do so well and a certain number of them did very well. We're trying to bifurcate those populations, and so that we call them out specifically.
And so that's kind of what works, and I think that's really important, and that you're doing it. And you did comment on the receptivity of clinicians, for example. But a lot of clinicians, and I'm saying this from my own past experience, didn't really know what implicit bias is or was at the time. And most people will say, well, no, I don't have an implicit bias, or I wasn't aware of it. But it seems now, at the same time the pandemic's going on, there's a lot more looking within, and people coming saying, well, you may have some implicit bias. Let's talk about it. How receptive, and I'll ask it to both of you, but I'm thinking of the clinicians initially, because Ascension is so much on the front line there. How receptive have the clinicians been? Is there resistance? There used to be resistance. People say, I just don't have time to deal with this. But how receptive have people been?
Yeah, I will tell you that the physicians see it as part of their normal workday today. I would say we've come a long way. And my predecessors at Ascension really sort of drove this in, and it's become so much a part of what we are and who we are. It's become a cultural phenomenon. And I think what happens is, as an Ascension physician, you sort of know what you're buying into when you sign up for us. You're going to see populations that others may choose not to see. You're going to see Medicaid population. You're going to see the uninsured. You're going to see the undocumented, because that's what Ascension has been about. And so we'll continue to push that culture as an organization. And I think culturally, the organization people will deselect from the organization if they don't buy into that approach. And we have some stories where we've separated from large groups that have hurt our health system, 40-person primary care group in Michigan that left our organization because that implicit bias, they couldn't get past that. And they were not going to see that population in the same way, in the same light. And to the detriment of our health system, we shed them. But I think in the long run, that will help our health system from a long term. And, you can't fight culture. I mean, I think people on this call know that culture really drives an organization.
Do you think that you had an advantage, or had an advantage, I'll say, put it in the past tense, because everybody I think is doing some better with it, because of your faith-based history, your mission right up front, your nonprofit status? Did you have a head start compared to other systems? And
yeah, I think
maybe
so.
an unfair question to ask, but it seems to me.
Yeah, I think the short answer is absolutely. Our sponsor calls us and holds us accountable. Our sponsoring organizations, the Sisters, the Daughters of Charity, and the Sisters of St. Joseph, the founding members of our organization, really created a system that was based on equity for care for everyone, healthcare for everyone, in an even way. And so, and that culture has just been, our mission has been around since the beginning of Ascension, which is now over 20 years old. It's been around, and that has not changed. That has been a consistent mission, and it's consistently been our guiding light through all this.
Yeah, but it makes sense. I think everybody's made huge progress. And I think in the last year, where discussions have been put on the table, even among people who are not comfortable putting it on the table, they soon see putting it on the table really opens up people's eyes. And that's the first step. Naisha, we talked a little bit, or Joe mentioned a little bit, about using data for social determinants, the non-medical determinants. And we know that healthcare disparities are commonly viewed through the lens of either race or ethnicity, but in truth occur across this much broader range of dimensions, economic status, age, language, sexual identity. Anything from your perspective in the research or at the bedside in terms of these larger determinants that Pfizer's involved with?
Yeah, absolutely. But if I may, I'd just like to pick up on one point that was mentioned in the last discussion around implicit bias and really holding yourselves accountable. So Pfizer has 4 values that we judge ourselves on internally and also externally in how we interact with others. And so one of those values is specifically equity. So it's written into our goals. We're expected to live by those. And equity is defined how we are seen, heard, and cared for. And so with that equity value, we are able to define what we need to do to improve on this measure. And so I think it's really important that, as Joe said, that we are holding ourselves accountable and these things are in writing. Specifically on, healthcare disparities across all these dimensions. I can give you an example of how we're looking at this in terms of cancer, if I can. And so we definitely believe that we all know the data on the diversity and also disparities in cancer care. One of those dimensions I think people may not pay that close attention to is age. And so aging and in cancer makes everything even more complex. We know that age is the greatest risk factor for developing cancer, and approximately 54% of newly diagnosed cancer patients are over the age of 65. And so what we've done at Pfizer is just understanding that this is a significant area of need and that this particular community needs different approaches. We've partnered with a lot of different organizations to make sure that we're addressing the differences in care that they face, wherever they are, whether it's at diagnosis or care at the bedside. And so some of those partnerships that we have, one is with the American Cancer Society, where we are supporting initiatives that's aiming to help reduce disparities between Blacks and whites living with cancer. We've also had a collaboration with the Association of Community Cancer Centers, where again, we use self-assessment tools to help healthcare professionals identify areas that need improvement in those older populations. We are recently launched a new section on our portal that's called This is Living with Cancer, and it's called As We Age, right? And it's a platform that's dedicated to providing resources, education, and encouragement for older people living with cancer. And this pandemic has done, so much damage for sure, but certainly in the area of preventing people from getting to see their physicians to get the treatment or even diagnosis that they need. And so we have another campaign that's called Get It Done. We're working with many organizations to reinforce the urgency and the need to get up screenings and follow up. Cancer waits for no one, and so we know time is of the essence. And so these are some of the ways that we're trying to make sure that we are bringing to the forefront tools and education that's needed to help specifically the elderly in this disease state.
No, that's fascinating. And Naisha, you mentioned sort of this collaborative approach. And so, Joe, let me turn to you from the Ascension standpoint. We know it's important to address health equity collaboratively. We can't just put it in a department or task a few individuals with it. But beyond that, and beyond within an institution, we need to leverage government, we need to leverage business and law enforcement and community resources. Describe a little bit how Ascension is in this taking a collaborative approach to this whole entity of both disparities and equity in healthcare.
Yeah, we struggled with this a little bit. We try to decide, are we going to try and be everything to everybody? And as a health system, as you know, Bill, with your background, we can't do it all for everybody. And so to me, it's about creating that community of resources together. And is Ascension, in many ways, we're thinking that we need to be the convener or be at least part of the convener and bringing community resources together in a collaborative way, because we can't be everything to everybody. We cannot solve the housing issues. So we're partnering with the Catholic Health Association around housing. We partner with local housing. We partner with the local food banks. We can't solve all the food insecurity problems. We can't solve all the transportation problems. So it takes a community to solve this problem. It raises the awareness and it becomes a collaborative that is owned by the community and not just a health system or one entity within a community. So I think to us, it's about getting that critical mass of community stakeholders together to pull this together in a way that is integrated and then delivers. And that's, I don't want to be an advertisement for Aunt Bertha, but honestly, I think they do an incredibly great job of pulling and becoming that dictionary or inventory of community assets to help our providers and become a resource for not only the patients, but potentially for the providers that are out there to say, well, you have a food problem, here's a resource, or go to this website. They can help you navigate the community, because this population does not know how to navigate and find things. And so I think for us, it's about helping move the dial as a member of the community and not in isolation.
I think the one thing that the pandemic has clearly done for me personally and my involvement in the community is that health and well-being takes a collaborative approach. And you can't just talk about collaboration, you have to do it. We have one of our sponsors today, Nashville Health, which is a collaboration that brings together the entire nonprofit and for-profit community that looks at not just healthcare, but this broader spirit of health. Nashville Healthcare Council, again, the co-sponsor today has these 900 members, both in Tennessee and around the country, that can be a vehicle calling for collaboration, for the fact that Bill Frisch used to be heart transplants and used to do heart surgery. But health and well-being is a lot more than that. And Joe, you hit right at it with the loneliness factor. That's a long way from Bill Frist, the surgeon. And I think this collaborative approach that brings together the tools to address it is what we're all learning a lot about. I want to just turn to vaccines, but before doing vaccines, Naisha, Pfizer, we all think of Pfizer as making drugs. What you've talked about, what we talked about, for the last 20, 30 minutes has been much, much, much bigger than that. And I know you did it in your introduction a little bit, but the manufacture of drugs and the great research, everything else that Pfizer does is how much? Or is it all imbued in a culture at Pfizer?
Oh, great question. It's definitely in the culture, right? So no one goes into science to say, let me just try to create something and see what happens, right? No one wants a drug to sit on the shelf. And so it's definitely within our culture. We think about how do we bring this product to market and to those who need it most. So it's definitely within our culture. You see it in how we're organized internally. In the past, there may have been silos, but we recognize that that is not in the best interest of patients. And if you want to keep them at the center, you want to bring all the people who have the expertise together to solve the various challenges. And so you'll have our head of research for a group sitting with development. So that are the people who are doing the clinical trials. And then they're sitting with the commercial folks. They're sitting with my team who are saying, how do we get it to the poorest of the poor? So it's really end to end, and we're not successful if we don't make sure that we haven't overturned every rock and stone to make sure our products are getting to the patients who need them. So it's definitely within our culture, and it's the only way that patients can be successful and that we can be successful, therefore.
Let me stay with you for a second on the whole drug development, vaccines, which every day, thank goodness, we're seeing the progress that has been made by Pfizer and other companies in terms of the vaccines themselves. But these next 3 to 4 months, or maybe the next 6 months, really do bring up big equity issues in terms of a scarce resource, a vaccine that we know is life-saving. Health equity and the various equities and disparities we've talked about become increasingly important. Put it in perspective for me as the vaccine begins to be administered, how we should be looking at health equity and how we need to take the potential disparities in access issues into consideration as this life-saving vaccine is out there and everybody wants it right now.
Yeah, so I think the great thing about this public health, this global pandemic, is that we recognize where people play best, right? And so while we play best at the development and understanding, how the different medicine is going to be helpful for the various patients, understanding that we have to make sure that it's working in all populations in order for anyone to even begin to think about trusting it. We also understand that it's, the local governments that are responsible for thinking through their population, who is most vulnerable, how these communities that have significant health disparities get access to the medicine. So we have in the US, for instance, we have state government relations colleagues who are calling on state departments all the time to talk about, what's happening here, how can we be helpful? So while it's ultimately their decision on how it gets dispensed, we have access to data and we have conversations where we can be helpful in helping them think through their process. With outside of the US, for instance, as well, we have a commitment to continue discussions with the COVAX facility to make sure that we are able to provide product to patients outside of the US as well. So our breadth and our reach within local governments, national governments, and even outside the US allows us to have those conversations as they're making that decision on prioritization and distribution as well. And the fact that we have a long history in vaccines really, I think, gives us credibility and allows us to be invited to these tables as they're making those decisions.
Good, thank you. And Joe, well, let me remind everybody, we've got great questions coming in. I'll turn the questions about four or 5 minutes or so, but keep your questions coming in. Just put them straight into the chat room and we'll get to as many as we possibly can. Joe, St. Thomas is right out the window here today, a great Ascension facility, and there will be probably 100,000 Nashvillians who are going to want this vaccine pretty quickly. As you take it to that sort of end point where people need to get it into their arm, and they'll be going to retail facilities and everybody will be involved. But how is Ascension looking at the equity issues surrounding vaccine distribution? Joe, you're on mute.
Yeah. This was something that we took up very early as the prospects of a vaccine becoming available late in this calendar year. We took up vaccine equity in the fall to start to really identify what are going to be the stumbling blocks to vaccine equity, and looking at specific populations. And we have a framework very similar to what the Institute of Medicine has come up with, as well as the Catholic Health Association, around how do we prioritize the populations that we're going to be. And it can't be a business leaders from across the community being lined up first. It's got to be those folks that are the most vulnerable to this illness. And in particular, we have a pretty regimented rollout structure for our markets, including our frontline healthcare workers, our more vulnerable populations. Ascension owns 55 nursing homes, so those are high on the list, and those will of course be coordinated through CVS and Walgreens. But we continue to work every day at the logistics, because the logistics of this double dose vaccine that requires -70-degree storage, has limited shelf life, vaccinating our healthcare workers as well as our vulnerable populations, collecting all the data points that need to be collected, both from the federal level, from the vaccine folks, and from the state level, is a Herculean task. So we have all hands on deck, and that's a meeting that's going on parallel to this meeting right now, is our all hands on deck vaccine meeting that happens twice a week right now. And each of the markets is reporting on their progress on how to get there. And a big part of that work is equity. I think one of the big issues about a vaccine and getting it to the right populations, I heard from CVS, their data on the consumer is 36% of Black African Americans are telling us now they will never get the vaccine, and 18% of Hispanics are saying they'll never get the vaccine. That is distressing, because it's the population that we really need to hit, because they're in many cases are the most vulnerable to this illness. What we don't have is we don't have trust. It was a nice article, perspective article on trustworthiness and trust in healthcare in the New England Journal this past month. If you haven't looked at it, it's really worth the read. Very quick read, but the issue is that in many of our ministries, and we're working on this, but we haven't gotten there yet. We don't look like the people we're treating, and we don't have the same background of the people we're treating. So we need to establish trust. If we need to have people that are treating the populations that don't trust us look and have cultural alignment with those same folks. So to me, this is going to be an important piece of healthcare during this pandemic. But I think it's going to be incredible if we're ever going to get to health equity and start to establish the lines of trust of the healthcare organizations that are out there. We're going to need to get a better trusting population. And I think not the only way, but a big piece of that puzzle is having people with cultural alignment and that look the same and have the same cultural background as we see in the populations we treat.
Well, yeah, that's really well said. Listen, I just looking at all the questions are coming in, and this is a perfect time for me to begin to turn to those questions. And the first question is on exactly that. And Naisha, I think it goes to you. It says, Tennessee has been selected as a distribution pilot state for the Pfizer COVID-19 vaccine. How do you build trust among populations who might be skeptical of the vaccine and then ensure equitable access to it? It's a question which really falls perfectly upon what Joe was saying.
Absolutely. Well, you don't start today, right? You can't just say, oh, I want to build trust. Let's get started. And so, fortunately, at Pfizer, we have a number of partnerships, some within our Multicultural Center of Excellence, where we work with organizations like the National Black Nurses Association, Dia de la Mujer Latina, which focuses on healthcare workers and those who are in the community. And so, we've known for a long time that there is distrust. And I think we do ourselves a disservice when we just say there's mistrust without acknowledging that that mistrust is well earned by those who have taken advantage and who have disregarded these communities. And so we work with these organizations to say, you tell us what you're hearing on the ground, what messages would resonate with these organizations. We allow them to then create those materials so that they can use those partners who are already in the community. So it's not Pfizer logo going in and say, you should trust us. It's people that they already know to help them really understand that things have changed since Tuskegee. Things have changed since Henrietta Lacks, and helping them to understand that. And we know that even when you give people information, sometimes it's really saying, oh, my friend is getting this vaccine. So maybe that gives me another level of trust. So it's really understanding the intersectionality of all these things. One message is not it. And for sure, do not come here and be one and done with the community. You must stay. You must have sustained relationships over time. And if you disappear after you've kind of gotten what you want, you will never be able to regain that trust. So it's really about sustainability, understanding what has caused those challenges, helping to educate, and then figuring out what to do next. There are a lot of coalitions who are developing really great materials. I think about Vaccinate Your Family as one of them. But we are working on these partnerships to make sure that people are listening, hearing the right information from those that they trust over the long term.
Yeah, I think both of you just come back to the trust end of it. And I think it's been confusing for the American people with the misinformation and the purposeful misinformation that's come from the very top. And hopefully things will settle out. But I think it's incumbent upon all of us, whether we're practitioners or research people or manufacturers, anybody involved in health services in the broadest sense and health, needs to keep coming back to that trust. And I think both of you have made that point. Another question that came up is about implicit bias. I appreciate the questions and comments about implicit bias. In addition to physicians, which I'd asked about, we know there's work to be done among others, other systems, policymakers, researchers, administrators. Would any of the speakers be able to address the role of implicit bias, unconscious bias, systemic racism in other areas beyond just the practitioners? I'd open it to either of you.
Yeah, I'm happy to start. I mean, if you live here, we all have implicit biases, right? And so I think if you say that you don't, we need to have you have a separate course to think through that. But there's a lot of evidence that suggests that even with healthcare practitioners, for instance, in the area of pain, some see pain in African Americans may not be as severe as other populations. And so it's incumbent upon us to make sure that as people are being trained up, either within the healthcare practitioner space, or people are coming in to be politicians or scientists, even like at Pfizer, we have programs where people have to take implicit bias training. So what does that look like for you? How can you question yourself to determine if you've made a decision based on this? So it's really that training, self-evaluation, measuring some of that as well. So it's no doubt that it is there, but we have to make sure that we continue to have the conversation. And if ever we are comfortable, we have failed because we shouldn't be comfortable until the health disparities are gone, because that really helps us determine whether or not we've reduced our bias and how we come to our work and come to really serve others.
Yeah, what I'm so amazed of, and I've done the formal implicit bias training, and also just the discussions. What I'm amazed of, and I implied it earlier, suggested earlier, that after people come in the room and you just talk about it, just open up to it, that it's not as scary or as frightening or as overwhelming as you would think. And then people leave the room almost without exception with a feeling of, okay, now I understand. Now I think that there's specific things that I can do, this sort of sigh of relief that once you have the discussion, just opens up new worlds. Let me turn to one more question. Again, have great questions. And this is a common question. It's a good one to come close to closing on. And that is people are listening to us and saying, okay, I get it. I understand what two great organizations are doing, but what can I do? I'm listening to you and I'm viewing you. And the question is, as a community, how can we as individuals and organizations help partners such as St. Thomas or Pfizer? I mean, it really comes back to, what can we ask people to do? Either one. Joe, you want to start?
Yeah, I'll take a stab at it. I do think that, first of all, we are part of the community. And so I think our workers, our nurses, our doctors all live and work and come from Nashville. So the community we're a part of that community. And the support that we get for our healthcare workers today in particular, through various programs and all the things that are happening for our healthcare workers are a big part of how we can support this work today during the pandemic. There's nothing like a pandemic to pull us all together. I think our organization today, Ascension, is much closer together as an organization because of this. We're in a trench together. And I think as a community, we're in a trench together. And so the things that I think that you all can do to support us during this time of crisis and to support the things that we're talking about today about equity is to be doing your part, whatever your walk of life is to be doing your part as part of that solution. And if it's volunteering at a food bank or volunteering and doing things to continue to raise awareness of the inequities that occur in our society, I think that's probably, and then candidly for large businesses is to continue to support the charities that work in our communities to help support the elderly, the infirmed, the people that don't have the same access. I grew up, I had access to whatever I needed. We all came from a background that gave us access. There are certain kids today that are not growing up with that same access. And I think we just need to continue to support that. We need to support education. When we look at our health equity, our social determinants, education was raised on a number of age groups as being something that was identified as an issue. And so continue to support education and public education in a way that supports the community that needs that education, because candidly, it's very hard to elevate yourself and very hard to understand things if you don't have that foundational education. There is some data out there about inequities in healthcare that is foundational, the lack of education and poor healthcare behavior or health-related behaviors are founded in lack of education. So supporting the community from a comprehensive way, both financially, supporting charities and education, it's really a community effort.
Yeah, well said, Naisha.
I would just say become educated yourself. And then you can fit and figure out what your passion is. It could be education. It could be serving in your local school district. It could be being in my kids' school, they called it being like standing up for others, right? So making sure that you are educated enough so that when you're in a situation that's not proper, you can talk through like what is the best behavior. But I think Joe said it well, especially when it comes to, just be involved, right? If you are doing the same things now that you were doing before the pandemic in terms of helping within your community, I would say take a look at that and see what more can be done.
Yeah, I think, the question was asked well, because it started with the big institutions, and both of you represent big institutions, but it's made up of individuals and it's made up of community, and both are part of the community. And, Margaret Mead's famous words of never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. I think it really does come back to every one of us. It doesn't need to be just the big institutions. Every one of us can make a difference. I've got about a minute left for each of you, and I hate this part of the program because we have to come to a close, but we've got just a few minutes left. There are no silver linings. We're right in the middle of a pandemic, and we're probably going to see the worst of it over the next 3 months. And it's hard for people to believe. And I spent a lot of time trying to share with people what I know, just being a physician and somebody who has studied these infectious diseases, but it's going to be really, really tough these next 2 to 3 months. So I say there's no silver lining. That's the way I open it. But there are some little elements of good. COVID has laid bare the longstanding inequities which we talked about in our communities and across our country and our practices and the way we deliver care. But not being a silver lining, but is there something out there that is good that's coming from it? Are we going to be better positioned to take a different trajectory as we move forward? And let me, Joe, let me start with you. And again, we only got a minute for each of you.
Yeah, I'd say we're much better as a health system, recognizing inequity in healthcare. I mean, Ascension was really good at it before, but I think today we're even more. You think the pandemic has exposed us even more, the inequities in healthcare. And so I think we're better at recognizing it. We're better at trying to fix it. You know, I would say that the one thing that we need to continue to think about, and I'll make this plea in my last 20 seconds here, our nurses, our frontline staff are really tired. This is the biggest, in most communities today, it's not a bed issue. We have the beds. We don't have the staff, and our nurses and our frontline providers are tired. Supporting that staff and coming together closer as a family and supporting our families and supporting each other, our neighbors, and in particular those in the field, the frontline workers, would be a great thing to do, and I think will bring the community even closer together, and really helping to not only help the people on the front line, but the people being affected by the pandemic.
Naisha?
I would say a good thing that's come out of this is that we are discussing these issues now, right? When you discuss things, you cannot fix what you don't acknowledge, right? So having that awareness is great, but we cannot be admirers of the problem. We must figure out what we can do individually. We must work with people within our industry, across industries, across the globe to figure out how to stay collaborative, be hyper focused on inclusivity, and make sure this is sustained. For me, it means I now have permission to challenge those who may not have been wanting to have this conversation before and say, you know, what are the receipts that you're really doing this work? And I think we all have that permission now, because if we don't use it now, we will find ourselves the next 20 years talking about this again. So the discussion is here. The responsibility is each of ours to continue it and to do everything that we can to make sure these gaps are eliminated.
Well, in both of you, I hear not just a diagnosis of the issues that are out there and the challenges that we have, but a real call to action. A call to action, and both of you articulated very well that it means we need to consider what's out there today. We can make a difference, but it's going to require us to act. So, Joe Cashone and Naisha Foster, thank you for a wonderful, wonderful, inspiring discussion. Let me flip it back to Caroline Young.
Thank you, Senator. And I also want to thank Naisha and Joe for candid, insightful comments. I will be taking them to heart, and I know that many of you in attendance will today also. I do want to thank our sponsor for the program, RL Datix. Thank you for your support in making this possible. I want to thank our partner, Nashville Healthcare Council. Over the past 3 sessions, you've been a great partner to work with. And lastly, I would encourage you to wear your mask, wash your hands, avoid large crowds, and have a great rest of the day. Thank you.